A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a presentation on adrenal incidentaloma and pheochromocytoma. This would be presented by our resident, Dr. Karan, and would be moderated by our faculty, Dr. Dharmendra Jangir. So I would request Dr. Karan to kindly share his presentation. Karan, please go ahead.
Thank you. Good morning, everyone. My today's topic of presentation is adrenal incidentaloma and pheochromocytoma. Adrenal incidentaloma is defined as any unsuspected adrenal mass that is greater than 1 centimeter on an imaging for relatively unrelated cause. Its frequency is around 5% and it increases with age, reaching up to 7% till 70 years of age. Most of the adrenal lesions can be metabolically active, around 11.2% are metabolically active, which include cortisol-producing adenoma, which are around 5%, pheochromocytoma 5%, and aldosterone-producing adenomas. There can be malignancy can be in up to 7% lesions, and nearly 20% lesions are potential surgical. For imaging of adrenal incidentalomas, ultrasound is a suboptimal imaging. Therefore, we get CT and magnetic MRI. They identify the presence of intracytoplasmic lipid content that differentiates it from benign adenoma. Unenhanced CT scan is done. In unenhanced CT scan, adrenal adenoma shows low attenuation value, less than 10 Hounsfield units, because of its high intracytoplasmic lipid content. However, 30% of adrenal adenomas, also known as lipid poor adenomas, show Hounsfield values greater than 10 Hounsfield units. And up to 7% adrenal metastasis can be less than 10 Hounsfield units on non-contrast imaging. And there are few low-density pheochromocytomas which show less than 10 Hounsfield unit values. Therefore, we get CT washout study done in which if there is adrenal mass and it has a Hounsfield unit value of more than 10 units, then we get a delayed scan of 15 minutes. If there is absolute washout of more than 60% or a relative washout of more than 40%, then it is diagnostic of adenoma. MRI also works on same principle. It detects the interference between signal from fat and water to evaluate for intracellular lipid content. Our CT washout studies have better sensitivity and specificity. Functional imaging is rarely required. It is only required when we are suspecting a metastasis or we are suspecting an extra adrenal mass. Usually we can get a radionuclide NP59 SPECT scan, dopamine PET scan, MIBG scan, and a FDG PET scan. FDG PET scan has a high sensitivity and specificity, but it is only reserved for cases with CTs and inconclusive. Incidentalomas can reach up to the size of 20 centimeters because of the large space in retroperitoneum. However, the average size is 3 centimeters. In lesions less than 4 centimeters, there can be less than 2% chances of malignancy. Therefore, they can be observed if they are non-functional with re-imaging at 6, 12, and 24 months. And if on repeat imaging, the growth increases by 1 centimeter, we should operate it. In lesions 4 to 6 centimeters, there is 6% chance of malignancy and they should be operated. In lesions more than 6%, they are malignant until proven otherwise and should definitely require surgery. Incidence of benign adenoma also increases with age. Therefore, adrenal lesions in younger patients should be treated with caution even if they are less than 4 centimeters. Biopsy is rarely needed in adrenal mass. Its only indication is if it changes the treatment or recurrence of a primary malignancy is suspected. However, it has certain complications like bleeding, pneumothorax, hemothorax, needle tract imaging. And pheochromocytoma should always be ruled out before performing a biopsy. Assessment of function of adrenal masses. Metabolic testing should be done for all adrenal incidentomas because more than 10% are active lesions. Routinely, we do catecholamine and cortisol hypersecretion screening. However, in hypertensive and hypokalemic patients, aldosterone hypersecretion should also be tested. Testing for cortisol hypersecretion, there are 3 first-line tests: low-dose dexamethasone suppression test, late-night salivary cortisol test, and a 24-hour urinary free cortisol evaluation. In low-dose dexamethasone test, we give 1 mg of dexamethasone at night between 11 to 12 p.m. and a sample is drawn at 8 to 9 a.m. Values less than 5 microgram per deciliter is normal. However, threshold of less than 0.18 is chosen because of its high sensitivity and specificity. Unlike 24-hour urinary free cortisol levels, it is not affected by the GFR of the patient. However, false positive results are seen in women taking OCPs. Late night salivary cortisol level, the saliva is collected at 11 at bedtime, and values less than 145 nanogram per deciliter are normal. Tobacco use should be avoided on the day of investigation. However, this test shows false positive results in patients with depression, chronic illness, or an altered sleep pattern. 24-hour urinary cortisol, urinary free cortisol level. It is a drug investigation of choice in patients, pregnant patients and patients on OCPs. 50 to 100 microgram per 24-hour urinary volume is the normal values. The threshold is increased up to 2 to 3 times in second and third trimester. It shows false negative results if GFR is less than 60. Testing for aldosterone hyperactivity, it is extremely rare and it is only recommended in hypertensive and hypokalemic patients. Aldosterone to renin ratio of more than 20 and aldosterone more than 15 ng per deciliter is indicative of Cohen syndrome. Samples should be drawn between 8 to 10 a.m. in sitting position, and potassium sparing diuretics and beta blockers should be stopped several weeks before testing, because beta blockers can reduce the value of renin and possibly show false positive results. ACE inhibitors and calcium channel blockers can be continued as they don't alter the need. Testing for adrenal sex steroid hypersecretion, DHAS, 17-hydroxyprogesterone, and androstenedione are tested. However, this is extremely rare and it is routine use is not recommended. It is only tested in which adrenal carcinoma is suspected. Testing for catecholamine hypersecretion, 5% of the patients in incidentaloma can have pheochromocytoma. Therefore, it should be done in all the patients. Plasma-free metanephrine and 24-hour urinary fraction metanephrines are done. Plasma-free metanephrines, the sample is drawn in supine position after 20 minutes of rest. Upper limit is 112 ng per liter for normetanephrine and 61 for metanephrines. Levels above 400 of normetanephrine and 236 for metanephrine are highly specific for pheochromocytoma. If they are less elevated, then repeat sample with urinary metanephrine levels, plasma chromogranin A level, and clonidine suppression test is done. False positive results are seen in patients taking caffeinated beverages, acetaminophen beta blockers, and phenoxybenzamine. 24-hour urinary fraction metanephrines, values more than 15 and 31 nanomoles per day of metanephrine and more than 4001 of normetanephrine is indicative of pheochromocytoma. Creatinine level in the collected sample should also be checked for completeness of the sample. Patient should be asked to discard the first void, and the sample should be collected till first void of the next day. And tricycline antidepressants and phenoxybenzamine should be stopped. 2% of the silent incidentalomas can show metabolic activity during follow-up this. Therefore, they should be followed up with repeat imaging at 6, 12, and 24 months. Routine biochemical testing is not done. Moving on to pheochromocytoma. It is a tumor of catecholamine producing cells. The incidence is around 1 to 2 million, 1 to 2 per million, and it is responsible for 0.5% cases of hypertension. It is seen in 5% of incidentalomas. They can also arise from extraadrenal sites when they are known as paragangliomas. Most common site is organ of Zuckerland located between the aortic bifurcation. Other sites are urinary bladder, mediastinum, carotid bodies. It is also known as 10% tumor because there are 10% extraadrenal, 10% familial, 10% bilateral, 10% pediatric, and 10% malignant. There are certain exceptions to this because up to 25% can be extraadrenal. Familial cases are up to 30% and malignancy seen only in 5% of the cases. There is great variation in catecholamine released in the different tumors. Tumors in von Hippel-Lindau syndrome predominantly secrete norepinephrine and thus hypertension and sweating are seen. Tumors producing epinephrine predominantly show syncopal attacks. Hereditary pheochromocytoma, it's around 30% and 5 genes are responsible, namely RET, von Hippel-Lindau, neurofibromatosis type 1, SDSD, and SDHP. Hereditary pheochromocytoma is usually seen at younger age and it can be multifocal and bilateral at presentation. In patients with Mantoux syndrome, they arise from adrenal glands and extraadrenal tumors are seen in VHL and neurofibromatosis type 1. Malignant pheochromocytoma. Malignancy can only be defined by presence of metastasis. Even local invasion is not considered as being malignant. It is much more common in extra-adrenal lesions. Malignant lesions are more likely to exhibit elevated dopamine levels, and they are usually larger than 5 centimeters. SDHP mutation is most strongly linked with the malignancy. Clinical features of pheochromocytoma include a triad of headache, episodic sudden perspiration, and tachycardia. Other clinical features include palpitation, sweating, pallor, nausea, etc. And about 20% of the patients can be asymptomatic. Diagnosis of pheochromocytoma is done by biochemical testing and imaging. Biochemical testing, we test for the metanephrines. L-DOPA is converted into dopamine, which is further converted into norepinephrine and converted to epinephrine with the help of enzyme PNMT, which is specific for adrenal. Epinephrine and norepinephrine are further converted to metanephrines and normetanephrines with help of enzyme COMT, which are further conjugated into sulfates. Catecholamine release is paroxysmal and metanephrine release is continuous. Therefore, testing for metanephrines is more sensitive than measurement of catecholamines. Urinary VMA levels can also be assessed, but they have a low sensitivity. Clonidine suppression test is done in patients in whom the diagnosis is equivocal, and chromogranin A can also be used. It has a sensitivity of 85%, however, specificity is decreased if GFR is less than 80. On imaging for pheochromocytoma, CT shows well-defined low lipid content mass of Hounsfield value of 30 units. MRI shows a light bulb sign. FDG PET scan can also be used. It is gold standard for evaluation of metastasis. MIBG scan was earlier used and had a high sensitivity of 83 to 100% and a specificity of 95%. It is indicated to localize when biochemical evidence is present and there is a negative cross-section imaging, or to look for extra-adrenal masses. Genetic screening should be done in patients who have a family history of pheochromocytoma or less than 50 years of age, who have multiple tumors, malignant lesions, and bilateral tumors. Routine investigation for neurofibromatosis type 1 is not indicated. Treatment for pheochromocytoma, robotic adrenalectomy is a standard of care. Hereditary pheochromocytoma and Mantoux syndrome and BHL have a very low risk of malignancy, but there are bilateral tumors, so we should do partial cortical sparing adrenalectomy. In metastatic lesions, palliative treatment is done. Surgical mastectomy can be done. Iodine 131 MIBG can be done, and chemotherapy using cyclophosphamide, vincristine, and dapagliflozin is given. Preoperative management, all patients of pheochromocytoma, even if they don't exhibit high blood pressure, should be given alpha blockade before surgery. Phenoxybenzamine is drug of choice. It is an irreversible blockage. Selective alpha-1 blockers include prazosin, digoxin, telazosin. We have two options. We can go for alpha blockade and a calcium channel blockade. Alpha-1 blockade is done using phenoxybenzamine with 10 mg dose BD, which is usually gradually increased up to total dose of 1 mg per kg. If patient starts having tachycardia or cardiac arrhythmias, beta blockers are added. Catecholamine synthesis blocker with metyrosine can also be used in dose of 250 to 500 mg BD. And if BP is still poorly controlled, calcium channel blockers can be added. And then day before surgery, patient should be given high intravascular fluids and salt diet. Rosen criteria states that there should be no orthostatic hypotension with BP less than 80/45. There should be no ST-T LVF changes 1 week prior to surgery, no more than 5 premature ventricular contractions, and no more hospital recordings of BP of 160/90. Post-operatively, patients should be managed for there's a risk of post-op hypotension if phenoxybenzamine is used in preoperative period. There is also a risk of hypoglycemia and electrolyte disimbalance. There's a 10% recurrence rate, 16% recurrence rate in 10 years. Therefore, they should be followed up. Biochemical testing is done at 6 months after surgery and is done annually for life. Post-operative imaging should also be done to check the complete resection of the tumor bed. However, there's no need for subsequent imaging if biochemical results are normal. Lap adrenalectomy can be done using transperitoneal and retroperitoneal approaches. Open adrenalectomy is done in tumors of large size, usually more than 6 centimeters, and in which malignancy is suspected. Laparoscopic transabdominal surgery advantages are that it can be combined with other procedures as well, and there's easier conversion to open, and it is more suitable in patients with obesity. However, if we have to do bilateral surgery, then we have to change the position of patient. And for retroperitoneoscopic, there is no need to change the position, and there is no need to mobilize the abdominal structures. However, it is not suitable for patients with obesity and in which there is a short distance between 12th rib and iliac crest. There's a video of robotic adrenalectomy, which surgeon is dissecting the left adrenal vein. The adrenal vein is then clipped and cut. The mass is dissected out.
Very good morning again. Thank you, Karan, for having that crisp and brief presentation on adrenal incidentaloma and pheochromocytoma. I think it's quite a, we could have done a little more on the subject, but anyway, so we all know adrenal incidentaloma is when we detect adrenal mass, which is more than 1 centimeter incidentally, when we are doing imaging study unrelated to the patient's symptoms specific to adrenal mass. So as imaging is being done more and more in patients, we are getting more and more kind of adrenal incidentalomas. And in fact, even pheochromocytoma, 60% are detected incidentally, and about 25–30% are detected on patients' symptoms. So we all know whenever there is a case of adrenal mass incidentaloma or detected after symptoms, we need to first differentiate between either this is benign or malignant, or it is functional or non-functional, and whether it needs surgical resection or need to be followed up. I think you didn't tell us about how to follow up the patients which are not operated. Not all patients need operation, right? Not every patient of incidentaloma needs surgery. So when we talk about benign and malignant, yes, there are imaging phenotypes, right? So which we can tell you suggest that whether this is a benign or malignant tumor, depending upon the size of the tumor first. More than 4 centimeters, you usually think that it could be malignant. If it is a smooth-walled capsule, if there is a homogeneity, or if the HU value is less than 10, right? So whenever there is a less than 10 HU value, then you would not never investigate for pheochromocytoma. So pheochromocytoma would be suspected only if it is more than 10 HU and you need to do the functional study for pheo. So at least it should be more than 10 HU. Then we have features like if there is a calcification, it goes in favor of malignancy. If there is a contrast washout, if it is more than 50% in 10 minutes, then it goes again in favor of malignancy. So these are imaging phenotypes which can actually differentiate between benign and malignant. Then there is a chemical shift MRI where it depends upon the lipid content of the tumor. So usually the benign tumors have more lipid content, and so there will be a chemical shift MRI which will tell you differentiate between benign and malignant, right? And then you have to find out whether the tumors are functional or non-functional. So we know there are 10 to 15% of these incidentalomas could be functional, right? And of this, about 3 to 6% would be a pheochromocytoma, 6 to 8% would be Cushing's, and about less than 1 to 2% less than that would be aldosteronoma, right? And about 0.1 to 2% can be malignancy, right? 2%. So what would you do the functional study? So in every case if you are suspecting pheo, yes, definitely you do a 24 hours plasma metanephrine or plasma fractionated metanephrines, which if there is a strong suspicion, you do only this plasma metanephrines, right? Fractionated. If there is a low suspicion of pheochromocytoma, then you do a 24 hours urinary metanephrines and catecholamines and plasma metanephrines. Then you have to know about whether this has a cortisol producing tumor. So most of these tumors are with subclinical Cushing's, and then there's a term called MAX, right? Mild autonomous cortisol secretion. So MAX tumor, that is the typical finding in adrenal incidentalomas, which occur in about 6 to 8% of cases, and which could be diagnosed by you have to measure the DHEAS level, dehydroepiandrosterone sulfate level, which goes down. So it goes down, it becomes very low in patients of this MAX. And then you have to do a 1 milligram dexamethasone suppression test, DST, where you give overnight 1 milligram of dexamethasone. Some people give 2 to 3 milligram. And then you measure the serum cortisol level at 8 a.m. next morning, which should be higher. So it's usually more than 1.88, right? So once you have proved that this is maybe a cortisol producing, then you do a serum cortisol level, ACTH level, and high dose dexamethasone suppression test, etc. Right? And the patients who are hypertensive or hypokalemic, either of them, then you would do a aldosterone level, always patient. So you do a aldosterone level and a plasma renin activity, PRA. So once you have differentiated whether this is a functional and non-functional tumor, because a lot of even pheochromocytomas may not show biochemical increase in these catecholamines and metanephrines. So they need a critical size, critical mass to achieve that level when you get these levels increased in the blood. So even less than 2 centimeter pheochromocytoma, you may not find any rise in these catecholamines and metanephrines. And then there are tumors like lipid poor and vascular tumors, which will again may not have this rise, but again they would require resection. So once you have diagnosed the functionality of the tumor, whether this appears to be benign and malignant, and then you do the investigation, as I said, imaging study, CT scan actually might tell you everything about the phenotypes of this tumor. And once, if you have suspecting pheochromocytoma, then never do a biopsy first. Biopsy would never be done in pheochromocytoma suspicion. And dexamethasone suppression test is also not done if you are suspecting pheochromocytoma. So if you are suspecting pheo, don't do a DST, which can create a crisis in many of these patients. And after doing the imaging study, preparing the patient, if there is a pheochromocytoma, then you do surgery. And what are the indications for surgery? So either you do a unilateral. So what are the bilateral tumors? So what are the conditions where you have bilateral adrenal tumors? So familial tumors, hereditary, syndromic, congenital adrenal hyperplasia, then lymphoma, metastasis, right? All these conditions you will suspect. If there are bilateral adrenal masses, these conditions could be there. So which patients require unilateral adrenalectomy? So any patients which is functional, you have to, whether irrespective of the size, you have to resect the tumor. Any tumor which is more than 4 centimeters in size, you have to resect because there's chance of malignancy, right? And patients who have MAX, that is mild autonomous cortisol secretion, and there is a condition called primary bilateral micronodular adrenal hyperplasia, right? So PBAH. So that requires, that may not typically present with Cushing syndrome, right? So they usually would present with some metabolic syndrome, right? Metabolic syndrome in the form of hypertension, diabetes, dyslipidemia, weight loss, osteoporosis. All these conditions may be present in such patients. So they would require a bilateral adrenalectomy. So sometimes these patients may have one large tumor, one small or tumor. Then you may do only a resection of the large tumor and not do a bilateral adrenalectomy. So many of these patients who are not functional and less than 4 centimeter size, they are suspected as adenomas, benign tumors. They have to be followed up. So the follow-up is like this, that you have to follow up most of these benign adenomatous kind of a suspicion. But every year you do an imaging study and a functional study, right? In the functional, again, you DHEAs and dexamethasone suppression test. And some patients who are suspected of being functional, they may have need a follow-up, which is more intense, that is 3 monthly or 6 monthly. So you follow them up at least for 4 years. Till 4 years, if there is no increase in size, so usually if it goes more than 3 to 4 centimeter, you will operate them. If the increase in size is more than 1 centimeter per year, then you would operate them. And if there are some functional kind of a biochemical increase, then you would operate them. If there is nothing like this for 4 years continuous, then you would not, they usually would not require any follow-up after 4 years. I think this was in brief about adrenal incidentalomas. If any of you resident faculty has any question, query, suggestion, comment to make, please let me know. And those who have joined us, if they have anything, please raise your hands. So, yeah, please go ahead.
Who needs antihypertensive drugs after the surgery of the PHEOCROMOCYTOMA?
What is the percentage? When does you expect the hypertension to become normotensive patient? Any idea? Next. So when do you expect them? When do you expect the blood levels to? Within 24 hours? Anybody? Third years, final years? Huh? अभी exam देना भैया, practical exam. And if the blood pressure doesn't get controlled, what could be the reason? And how do you investigate them further? Adi, you want to say anything? Yes, come. So when does the BP gets normalized after surgical resection of pheochromocytoma?
When the BP gets normal even 24 hours after the surgery, because the T-off of these get cold means in minutes. But in few cases, there may be incidence of essential hypertension, the first one, and there may be also the because of chronic hypertensive changes in the blood vessels, patient may need long-term antihypertensive. Yes. And there may also be other extra adrenal, or we may also know the paragangliomas.
5%. So these are the reasons why the blood pressure may be even high after your surgery. As I said, one could be the patient may have essential hypertension also. One, because of chronic hypertension, they may require sometimes. And if there are extra adrenal lesions, so by that we have to investigate further by imaging study. MIBG is one of this scan. PET scan is usually for metastasis. If you want to know extra adrenal functioning lesions, then MIBG scan is usually performed. Right. So anybody? Yes. So now we will go to the MCQs. The first question is, with regard to pre-op pheochromocytoma blockade, beta blocker should be started 2 weeks prior to adrenalectomy, at least several days prior to alpha blockers to control tachycardia and arrhythmias that can result upon initiation of alpha blockade in conjunction with metyrosine? Never, because metyrosine can be lethal in patients with fever. Answer C. To control tachycardia arrhythmias that can result upon initiation of alpha blocker. So I think yes, not every patient will require beta blocker therapy, though alpha blocker we would give in every patient, right? How does one perform a low-dose dexamethasone suppression test? Admit the patient and measure serum cortisol level every 6 hours while the patient is on a dexamethasone drip. Measure the patient's saliva cortisol level at midnight. Obtain a 24-hour urinary control cortisol measurement after the patient receives 1 milligram dexamethasone with the first void. Have the patient take 10 milligram dexamethasone at 11 p.m. Have the patient take 1 milligram of dexamethasone at 11 p.m. and measure serum cortisol the next morning at 8 a.m. Right? So usually you do it at 8. So E, right? That is, we all know. Which class of antihypertensives is contraindicated during the evaluation of primary aldosteronism? Calcium channel blockers, alpha blockers, beta blockers, aldosterone receptor blockers. Beta blockers? Okay. No. Aldosterone receptor blockers. So definitely this is quite obvious. Huh? Why did you say beta blockers? Huh? Any reason of saying beta blockers? Again, you have to be very clear whenever you measure these, do a functional study, there are a lot of patients would be on many drugs, right? So the ideal thing is to put off the drugs at least 2 weeks before doing the functional study. There are many patients who are on amitriptyline or tricyclic antidepressants and SSRIs. They can actually hamper the measurement of these. So you have to make sure that these patients are off drugs for at least 2 weeks before you measure the various biochemical parameters. What percentage of patients with incidental adrenal masses prove to have pheochromocytoma? 1%, 5%, 10, 25, 35. 5%, usually 3 to 6%, so average would be 5%. The maximum is max, that is mild autonomous cortisol secretion, which is around 6 to 8%, and the least is aldosteronism, which is around 1%. What genetic abnormality is strongly linked with malignant pheochromocytoma? RET, VHL, SDHB, SDHD, all of the above. VHL. C, SDHB. Okay. The syndromes which are associated with pheochromocytoma are? So MEN2 and VHL. Neurofibromatosis. Yeah. Okay. So SDHB mutation. Patients with multiple MEN2A and 2B possess a mutation in the RET proto-oncogene. Approximately half of these patients develop PHEO, but only about 3% of those with PHEO exhibit malignant potential. 10% to 20% of patients with VHL develop PHEO, but only 5% of those with PHEO have malignant disease. PHEO among patients with neurofibromatosis type 1 is rare, but malignant disease can be seen in more than 10%. Familial paraganglioma syndrome carries the highest risk of malignancy. Among patients with the condition who develop PHEO, its pathological cousin, familial paraganglioma syndrome type 1, carries a negligible risk. Right. So a 43-year-old woman undergoes an uneventful right laparoscopic adrenalectomy for a 4.5 centimeter PHEO. The patho report states that the lesion is benign and that the margins are negative. On post-op day 1, she is ready for discharge and wants to know if an additional follow-up is necessary. You inform her that the following is required: consideration of genetic screening, repeat metabolic testing in 2 weeks, cross-sectional imaging in 6 months, biochemical testing in 6 months, and then lifelong biochemical testing, all of the above. All of the above. So they require genetic screening. After less than 50 years old, it is pre-op or post-op? Post-op also. Achha. Repeat metabolic testing in 2 weeks. Okay. And cross-sectional imaging, 6 months too. Okay. So all of them. So the patient is less than 50 years old. Therefore, genetic screening is recommended. Up to 25% of patients who appear to have a sporadic pheo on presentation turn out to have germline mutations upon genetic testing. Repeat metabolic testing at 2 weeks after resection is prudent. Most experts recommend additional biochemical testing at 6 months, followed by annual lifelong screening. More than 15% of patients will demonstrate recurrence of pheo in the first 10 years after a successful resection. A recurrent disease has been reported more than 50 years following adrenalectomy. Therefore, lifelong annual biochemical screening is advised. Although cross-sectional imaging is not absolutely required in the face of a negative biochemical workup, most surgeons obtain at least one study at some point during the post-op follow-up. So again, as you said about adrenalectomy, robotic is not the standard. Robotic, those who have robotic, they can do definitely, but definitely laparoscopic has become the standard of care because most of the centers do have laparoscopic equipment. So definitely much better than the open surgery. A 55-year-old woman presents for the evaluation of an adrenal mass. Past medical history is significant for severe hypertension requiring 4 oral medications for adequate blood pressure control. A non-contrast CT scan of the abdomen reveals a 3 centimeter left adrenal mass with an average of 7 HU. Appropriate initial screening should include. What should it do? Free fractionated plasma metanephrines, plasma aldosterone concentration, LD, DST, and serum catecholamines. Late night salivary cortisol test, plasma aldosterone concentration, PRA, 24 hours urinary fractionated catecholamines. So again, as I said, if it is less than 10 HU, then you did not examine these patients for pheochromocytoma, right? So if there is hypertension, then definitely yes, aldosterone. You should. Nimesh, please. Nimesh. So C. Yes. So C should be the answer. Late night salivary cortisol test, plasma aldosterone concentration, PRA, and plasma-free metanephrines. And plasma-free metanephrines also? Usually they say that if it is less than 10, then you need not.
Complex hypertension.
Complex. Even if there is complex, the chances of aldosteronism and cortisol producing tumors will also produce hypertension. So again, the usual.
Given the patient's history of hypertension. Because the hypertension is.
Given the patients, always you should estimate aldosterone level. If the patient has hypertension and or hypokalemia, you should always measure the aldosterone level, right? So, okay, anyway. What test is considered the cornerstone for modern pheo biochemical testing? Plasma catecholamines, plasma-free metanephrines, or fractionated urinary metanephrines, VMA testing for fasting morning urinary norepinephrine, adrenal vein sampling for catecholamines. B, plasma-free metanephrine or fractionated urine. So that's the ideal, I think, or even metanephrines and catecholamines sometimes. So as I said, if there is a low suspicion, you do all the plasma plus 24-hour urinary metanephrines and catecholamines. If it is a strong suspicion, only plasma fractionated metanephrines would do. So VMA testing is not very sensitive and specific. Thank you. So that was all. If anybody has anything, so Nachiket, you want to say anything about this? Anybody?
The second last question. That would be the adequate screening test for any person who is presenting with refractory hypertension. One test for Cushing-White syndrome, one test for hyperadrenalism, one test for pheo. So I think that's a good question because that is how you proceed in the OPD.
Yeah, any patient of should get all kind of functional studies. Even patients. So what I was saying was for incidental. So if the patient has been diagnosed as incidentally and the tumor is less than 10 HU, then you did not investigate for pheochromocytoma. If it is less than 10 HU. If it is more than 10 HU, you have to do a functional study irrespective of the patient is symptomatic, hypertensive or not. Right? Because many of these patients may not be hypertensive. Many of these patients may not be symptomatic, as I said, because it requires a critical mass to get the patients become hypertensive and positive on biochemical testing. So there may be patients with small tumors which may not give you this kind of a result. Okay, anybody? Anyway, so thank you. Thanks, everybody, and have a good day.
This is a very important